Good morning, Africa, and thanks for the invite. Get ready to be immersed in a new sharing experience about ultrasound use in pregnancy. Today we will see state-of-the-art images and video clips, but also ugly, blurry, imprecise views with old machines. Just because if you know how things are barely seen, it's going to be easier for you all to spot clearer signs with better devices. So let's move ahead. First of all, I would like to call your attention to the memories of Radius study. Radius was a paper published on the New England Journal of Medicine back on 1993. Nowadays, it's a free access full paper. The design of Radius study was like this. They sent a survey to several centers and collect data, basically. Conclusions of radio study were not to advocate for screening ultrasound examination as a perinatal outcome for mothers and babies was the same, no matter what we do. I should say that in Mexico, 90% of all babies with congenital heart defects do not receive proper treatment, and as much as 30% are not even diagnosed. Congenital heart disease is number 2 cause of death on younger than 5 years old. So I recommend you scan everybody and do your best. We can save lives. In order to be helpful, it's crucial to perform whatever we do in a warm, sensitive, empathic manner. So I will show you first what we already know. What happens whenever we see a pregnant woman? Our service is not just informing about a thing, not even about a human being to be born. This is dealing with the foundation of human society, the family. Either if we find a perfect baby or some difference, sometimes ultrasound is, and I quote Dr. Roy Feely from California, ultrasound can be the best way to terrify a pregnant woman. And I will add, and a family. Let's take a look at these next clips. We can notice from this nice state-of-the-art imaging view of an early second trimester baby that something that do not look like it usually should. Baby has something. Above the neck, something looks different. From the ultrasound device monitor, this is what happens. And this is the same baby from a face-to-face viewpoint. Above the neck, the upper skull, something is wrong. And as I told you, as we all care from the human side and we are not machines selling services, but human beings taking care of another human being, we must acknowledge that almost every single mother has a big smile of joy and hope, regardless the context. And many of them have another big sister or brother waiting for the new member of the family, who you can see here kissing the mother's belly, plus a sometimes caring husband. And this picture of happy expectation preludes sometimes real tragedies. Because losing a child, no matter what the situation is a tragedy for most mothers, if not for all of them. You can notice this was an old machine, not endocavitary, but transpelvic examination. But we can see the problem as well as we did with the better machine. We agree now that we can be useful and accurate with the use of inexpensive devices as well as new machine models. Something above the neck is missed, wrong, different. So in the past, on my father's early times as an obstetrician, maternal care practice and related fields were like a walk in the courtyard. A pregnant lady entered our office, we smiled, saluted, took notes on general data, weighted her, took her blood pressure. Well, you better take the blood pressure first, then weight her because the weighting, somebody can rise the blood pressure high. Ask her to put a robe on and lie in the couch or examination table, palpated the abdomen, measured, if possible, the uterine fundus, used a binocular stethoscope or a regular one, or if we were lucky enough to have a Doppler device, search with the Doppler device in order to try to hear a heartbeat. After all that, we used to say, everything seems to be fine. And she answered back, thanks, doctor. She made the next appointment, paid, and left. Nowadays, and since the advent of ultrasound machines and the race to be faster, nicer, and more impressive than our colleague across the street, our everything is fine is different from any other everything is fine. We started having different levels of academical background, technical expertise, and communication skills. So interacting became more and more complex. There's a joke at the US about the levels of ultrasound. Whenever other doctor advertises himself, herself as a first level ultrasound facility, we used to say, okay, if that's first level, mine's gotta be at least second level, and so on, and so on, and so on. So certification agencies started kind of regulating things, kind of. For many years, I resisted the temptation to perform and to charge the so-called structural genetic examination because I have been always struggling to convince obstetricians to perform decent, full skill and well communicated examinations, to do the best possible service with our own resources and to improve that in a permanent basis. In fact, I have some files with structural obstetric reports as far as more than 20 years ago, but people ask for more papers, numbers, info, and gladly pays for it, and here we are. Dr. Pedro performing full structural examinations. Okay, enough for that. Having said so, take a look at the slide. If we are not skilled and there's an ultrasound machine, we must do basic examination for emergency triage purpose. I just coming back from the local general hospital because somebody said that 22nd week the baby didn't move. And then I said, well, you have an ultrasound machine in the emergency room. Use it. And then the emergency physician in charge turn it on, and I tell her how to search for the heartbeat, search for the movements. She didn't need to pay me for a structural ultrasound examination, just reassurance, simple triage. The more we see, the more we know, and the more we help. So we will jump up several steps to be able to obtain the decibel level, key images of anatomy, heart, abdomen, movements, amniotic fluid volume, blah, blah, blah. And why not aim for the ideal scope of using this prolongation of our site-name ultrasound imaging? Remember, this is not X-rays. This is clinical examination. It's a prolongation of your site. This is a tool to actually see inside the human body. Once we organize our protocol and know better what to search for next, it becomes easier and easier to integrate a more complex diagnosis conclusion. Have always in mind that no one has to know everything. There is no human being that knows everything. Yes, you should attend medical education activities such as this lecture and prepare yourself, but it is realistic to know where to search in complex cases. If you go to OMIM's website and input findings, chances are you will find several diagnostic options. Okay, let's start with the head to toe scan, actually head to hip. In this view, if we are experienced enough, that is, if you have seen several normal views, most unusual things will jump to your brains through your eyes. We see a symmetrical head, heart pointing left, stomach below, both normal kidneys, bladder center, and above all, we make sure that the baby is alive. Normal head is symmetrical, has a midline. That midline should be centered and interrupted by a square-shaped structure in the front side named cavum septum pellucidity. Biparietal diameter is the wider transverse measurement at the level of thalami. Below that we found cerebral peduncles. Below that there's posterior fossa containing cerebellum and cisterna magna, and a frontal aspect with both orbits and nose, lips, and related structures. Again, biparietal diameter is the widest transverse measurement of the cranium, where you can spot midline, thalami, and cavum septum pellucidity. This is a transverse cut of the cranium, lower than biparietal diameter and shorter. Here we see the cerebral peduncles. Uh, and the cavum septum pellucidity is not a square-shaped thing with the three lines structure. So we move up in order to have a good biparietal diameter, like this one. So sometimes we have suboptimal biparietal level shots to measure, and that lacks of precision. An anatomical landmark is to differentiate between thalamus and cerebral peduncles. Thalami is like a narrow tail with the arrow tip pointing front, if you can imagine that. Cerebral peduncles instead are similar, but as the arrow tip were pointing back and darker on the grayscale. So here we search for the right biparietal level plane. In the biparietal level, we can measure lateral ventricle and hemispheric width. The choroid plexus should fill up the whole lateral ventricle width. More or less at the level of pedunculus, we search for posterior fossa structures such as cerebellum and cisterna magna. And we measure cerebellum with which in early second trimester, like 18 to 22nd week, is the best single measurement to investigate gestational age, along with femur length. And as I was telling you on the posterior fossa, we search for cisterna magna, which at any time should measure less than 10 millimeters, like this one. The orbital plane is important because a number of pathologies show wider or narrower spaces between eyes. This is hypertelorism or hypotelorism. If we divide outer orbital length by 3, we will have the three structures fitting more or less each 1/3 of the measurement. And this slide shows the proper orbital plane shot. Tilting a little bit inside or around the orbits, we can spot the lens, which should be a ring-shaped structure with no echoes inside. So in that view, we will be able to rule out congenital cataract. So this is the left eye lens. You can tell that because the spine is at the left side, so that is the more anterior lens on the maternal abdomen, so it should be the left eye. And the opposite side's eye lens. Measurement of the nose bone length is important, and it shows like a bony bright line below the skin on the nose and the midline, at the face midline. You can notice that I'm showing real life, non-perfect examination stuff, real life shots, not precisely perfect stuff. But we should learn the perfect way. I will refer you to the Fetal Medicine Foundation courses or online to any of the different resources of education. The nose bone measurement importance began along the efforts to define signs of risk for Down syndrome. At first, this was designed to allow early detection of such babies as a leading cause of mental retardation, so to speak. And we all know that the main reason was economical cost of letting different people to live and needs for further support of special needs. And Dr. Roy Philly from California mentioned once in a meeting on the warfare edition of Ultrasound that if there were soft markers for simple minders like he and I, back around the 60s or 50s for his case, neither one of us could probably have been born. And below the nose, in a lower twisted image, more or less tangent to the face, We can see integrity of the upper lip with no need for a volumetric shot. Upper lip. Here we see it. So a shot like this is enough to rule out a cleft lip. So to finish a decent head, skull, and face examination, we align the column flow pointers to obtain mid-cerebral artery blood flow spectra. The mid-cerebral artery flow pattern changes in conditions such as low reserve, imminent delivery, fetal anemia, fetal distress, fetal acidosis. And of course, if we have a volumetric transducer or rendering software, we can see faces such like this. Now let's move down to the chest and focus on the heart. This is a long heart axis view with a four chambers view. Always keep this image on your minds. Heart of the heart chamber closer to the chest anterior wall is the right ventricle. Heart apex is pointing to the left side of the chest, and each auricle is on this slide at the left side of each respective ventricle. This is more posterior than the ventricles. Interventricular septum should be noticed, and ventricular width should be more or less similar. This is septum more or less centered in the heart. And the great vessels outflow seen aortic outflow from the left ventricle and pulmonary outflow from the right ventricle. Crossing at first and in a higher view level in a V-shaped pattern as the aorta comes back left front and down from the arch. This is after the great vessels first cross cephalic from the arch, both arteries blood flow is towards the same right to left direction. Evidently, the heart of the baby is not abnormally enlarged, and the cardiac index, this is the proportion of the chest occupied by the heart, is within the normal range. An apical four chambers view should show symmetrical ventricles, a central septum, and it is the ideal way to view to interrogate tricuspid valve blood flow normality. This is to rule out abnormal tricuspid regurgitation. As I say, tricuspid valve should not show a more than 50 centimeters per second jet of regurgitation. Of course, we should see both normal lungs without cysts, without other masses, each side of the heart. Like in this view, And I must tell, most physicians do not care much about seeing the thymus, but it's important to document presence and normality of the organ. Showing those pics are a good way also to impress the other person who says she or him performs ultrasound examinations better than ourselves. Now we move down the abdomen and see the gastric chamber below the heart on the left side, and the urinary bladder as the biggest anechoic structures inside the abdomen. This is the two big black holes, one left-sided below the diaphragm and the other one close to the hips. Urinary bladder, gastric chamber. So in this view we have from left to right on the screen bladder, stomach, diaphragm and heart, both lungs, so left kidney. And there are other several black or anechoic structures normally seen inside the abdomen, the umbilical vein, the gallbladder, and perhaps some intestinal images. Measurement of the abdominal perimeter is used for the estimation of fetal body weight, along with head and femur measurements. Put in charts and then the machine says estimated fetal body weight. Inside the abdomen, we have the kidneys, left kidney below the stomach, here, heart, stomach, kidney. So left kidney and right kidney at the opposite side of the spine below the liver. We move across the spine and we find the opposite side kidney, liver, kidney. And here on the slide, we also have mentioned the small fusiform anechoic cavity at the right side of the umbilical vein, which is the pointing right of the abdomen in a transverse view. We should also check for the umbilical insertion, ruling out hernias, omphalocele, or worse things, bigger things. Here it is, the static slide. And locating, whenever possible, the ductus venosus, which is a high-speed communication between the umbilical vein and the vena cava before entering the heart and not passing through the liver. That's one of the reasons why many colleagues don't perform structural examinations. So if you see the jet, in that point we have the ductus venosus. So we set the speed of the color and investigation to fast high. Close the window to 2 millimeters. In order to be able to spot the waveform of the ductus venosus blood flow. We should show an auricular or A wave on the same direction of the rest of the pattern. This is, we have a positive A wave, normal. Then we measure the femur and all the rest of the long bones, tibia, fibula. On the upper aspect of the base, ulna and radius. Plus, obtaining normal views of the spine, which should show no masses or defects on the normal lining. Skin covering the spine at all levels, particularly on the lumbosacral segment. We also see feet, and the angle between leg and foot which should be normal, usual, nice. We can measure feet length, use that for counting toes. And we can count toes, fingers, check for the presence of two umbilical arteries. And the normality of the waveform of the blood flow in the umbilical vessels. This is a marker for fetal distress. So we can document fetal well-being. This, along with the mid-cerebral artery Doppler interrogation, allows us to spot changes of the low reserve and fetal distress in a timely manner. So we finish with the baby normality details and move to the placenta location relative to the cervix and to the uterine wall and its appearance. So no more baby. Here we have the placenta, which in this case is fundal posterior or high posterior placenta, which strictly speaking should be measured from the transvaginal approach, but can be confidently evaluated from the suprapubic view like this one. should be no shorter than 3 centimeters. Here we have what we mentioned before, distance between cervix and placenta with the visual advantage of the extended view some devices offer. Investigating the uterine arteries is not a difficult task and allows us to detect patients with high risk of developing pregnancy-related high blood pressure. Here we see the cross between the iliac and uterine artery. Normal low resistance waveforms should not have this notch. The higher the resistance, the higher the odds of preeclampsia. So this patient has a right protodiastolic notch and a very subtle one on the left artery. Usually not such as high risk, but that will depend on genetics, feeding habits, lifestyle. So this is an almost normal, or you can consider normal waveform of the uterine artery. Subtle notch. We can include also on the report measurements numbers, charts, which usually come from the device. That was normal, but what if something different happens? I must tell you that we are not a referral center, never worked on big hospitals after our training, and always been on the private practice field. The next slides and video clips are all from our own patients' experience that have been collected along the many years on this field. I will present either nice new state-of-the-art stuff as well as an old machine, I told you, imaginary. So if you keep that in mind, meaning is anyone skilled and careful enough can give accurate info to patients and doctors, either good or not so good news. We are going to review more or less from head down, but some of these patients have complex multi-organ affectation, so be attentive, be positive. So I must say again, we are not machines attending people or serving people, but people serving other people. Sad to say, studies show more empathy for patients from a chatbot than from many physicians. But on dealing with such a unique situation as pregnancy, things like this can happen, have happened at my office for years. That was me encouraging family to show love for mom and the baby to come, just to find out a bit later that this will be a grief and loss situation, like with this particular patient who is going to deliver uh, an affected baby. Here we see a small head with some cranium. And in a zoom view, we see some of the flat bones, but not all. So when we are not able to recognize some parts of the baby cranium, we can call the situation as anencephaly. This is typically related to folic acid lack, and therefore in many countries we don't see much of these babies at present time. This is a video clip from 2007, taken with an old ATL Ultramark machine. We were, as far as I know, the only facility on the world performing volumetric reconstruction using such a machine. Let me show you.
No, ya está bien.
With the use of an
No, ya
external
está bien.
post-processing platform,
Por razón.
we were able to show
Te voy a
these
hacer un
peaks
reporte por escrito que diga todo eso.
in a
Tú tienes seguro, ¿verdad?
low budget
¿Y cuándo tienes
situation.
tu cita en el seguro?
This clip clearly shows bulging brain with no skull flat bones at all. We can call this a crania, and in this baby we see the brain uncovered and a midline face cleft. Here. No flat bones on the cranium. Midline cleft. Some other babies show big fused ventricles, such as this semilobar holoprosencephaly. I'm showing the whole video clip for most malformations, so we have a real-time scope of how does it look like. Big ventricles, face, lips, fused ventricles, communicators. Semilobar holoprosencephaly. Okay, again, same cranium, wide fused ventricles except for posterior horns, a very rudimentary cortex, almost no cortex, partial midline and corpus callosum, and small choroid on the sides. With a normal midline on the face. See, the choroids are the bright white areas on the margins. Like those. Some head and brain differences are sided. Like in this case where we find a lateral ventricle dilation sided with an echogenic focus or a solid calcified mass on the affected side. Along with the dilated cisterna magna, that's the calcification. This is a patient with infection due to cytomegalovirus. Other babies show cysts like this. Midline echoes-free spheric mass suspected to be an arachnoid cyst. Some of those are fully asymptomatic, and some others are persons who show some impairment like balance disturbance, headaches, seizures. That's an arachnoid cyst. Well, ventricular dilation or hydrocephalus can be seen with the use of very basic machines. We should scan the spine integrity in order to complete the diagnostic of the cause of the intracranial problem, such as in this babe with the closed myelomeningocele back from 2007. So, see the dilated ventricle, and then we move on the sky, on the spine, and see the gut bulging mass of the skin in the area of the defect. On that examination, we use a phase array low frequency transducer due to the patient's body conformation. We see more and more big patients. And with the use of smaller higher frequency transducer, if possible, we can see it in more detail. This is a 10 megahertz transducer with no harmonics. Remember, this is an old machine, but we can see the myelomeningocele. The main structure which communicates between brain hemispheres is the corpus callosum, and in some people is not fully formed or even completely absent. First sign is the absence of the anechoic frontal side square-shaped structure in the midline we call the cavum septum pellucidi. So instead of the anechoic quadrangular square structure, we see three parallel lines. Typically, this comes with big, elongated posterior horns named colpocephaly. And we can sometimes see the pericallosal artery course, particularly if we use the endovaginal transducer in a cephalic presentation baby. So 3 lines instead of cabum, long ventricles, long posterior horns. Three lines instead of a square cavity. Colpocephaly. And the image of the corpus callosum, which sometimes you can delineate, I told you, by Doppler coloring the pericallosal artery. This baby had a large cisterna magna also. And mild ventriculomegaly. When we search at OMIM website, we can get a full scope of things to search for in order to rule out more complex conditions than isolated, partial, or total agenesis of corpus callosum. Let's take a look at this video clip. We see a baby whose head is evidently small, and we can call that as microcephaly. Microcephalia we say in Spanish. So the head is unusually and evidently small. This is an early second trimester pregnancy. And you can see the measurement doesn't fit the age. Well, some babies have complex situations, and ideally we should know how to integrate a syndrome, like in this case. We have a baby with ventriculomegaly. The lateral ventricle is wide. Hypertelorism. The orbits are separated more than normal. High drops. Free fluid in the abdomen, ascites. The bones, the long bones, are short and are moth-eaten bones. See the spots. As fibula, tibia. Babies has ventriculomegaly, but micrognathia too. And when we input on the OMIM website, most things that we find the possible diagnosis of Greenberg dysplasia. or mouth-eaten skeletal dysplasia, chondrodystrophy, hydropic, and prenatally lethal type. We can even get the place of the genome where it resides. And with volumetric rendering, it's not too difficult to see the facial clefts. Bilateral, this case. Which belong to the same baby. And this showing the tongue in the long axis protruding through the lips defect. Told you, sometimes we see nice face shots with normal upper lip, but a palate cleft. Some other babies show just a cleft lip. Anyway, it can be seen, the midline clefts with the regular grayscale non-volumetric render imaging. And some of those babies have more complex syndromatic or chromosomic defects, like this baby with the complex midline defect, big ventricles, cleft lip. That makes afterbirth management much more complicated. So once again, integrating a syndromic diagnostic is not that difficult once you know where to search for. We just input dwarfism, short ribs, and so on, and we will get a name and surname for the situation like this: chondrogenesis type 2. So if you can see that in these poor quality images, you can do anything. So we know this is a baby inside the mommy. So the left side, we have urinary bladder, prominent abdomen, and on the right side, the small chest. You can notice the rib points and shadows. Some pleural effusion, transverse cut of the abdomen. Told you short ribs. See the white, bright, short lines. And this is the humerus, which is dramatically short, as well as the femur, failing like into the 15 weeks measurement in a 28 weeks pregnancy. So we have a severe micromelic dwarfism. Plus a translucid cranium. And this face shot otherwise normal. Now, we see a baby with cleft lip, but in this case, as a part of a complex situation with absent cavum, enlarged, probably polycystic kidney. Kidney goes from here to here, almost from the lung, see the ribs, shadows, to the hip, which is unusually big for such a baby. extra fingers and toes, and a big ventricular septum defect. This is the septum. Plus abnormal feet, rocket bottom feet, leg, foot. So if we search for combination of those signs, we can find a possible diagnostic upcoming website. Chondrogenesis type 2, Langer-Saldino type. This baby was seen as 22nd week and diagnosed with thanatophoric dysplasia. Mother searched for second and third and fourth opinion. And then she came back at the third week. And this is the 33rd week examination. It shows abnormally shaped head, small thorax, prominent abdomen, normal amniotic fluid, urinary bladder and stomach, short, very short, long bones, that's humerus, so evidently something is wrong. This baby's problem with life is small lungs due to small chest. Pulmonary hypoplasia, they don't have respiratory movements to exercise those lungs. See the chest? This transverse view of the chest is really small. And so this was the disease, and the first sight shots were this. The baby had cloverleaf cranium due to some degree of cranial synostosis, the abnormal shape of the cranium. A small thorax with short and straight ribs. That's the abdomen, that's the thorax. Abdomen, thorax. Proportion between abdomen and thorax is very shown here. Prominent abdomen, small thorax, and short femur, as well as all the long bones, which makes the difference with the so-called type 2 thanatophoric dysplasia, which is a disease with normal femur length. This is type 1. Here we see also short humerus, short cubitus, radius, tibia, and fibula. Matthias was born at full term, survived the war almost 1 hour, passed away due to respiratory distress as predicted, secondary to pulmonary hypoplasia. We all were prepared. When I saw him to stop breathing, I took him out of the incubator and told Mom, You're going to help me. Take him in your arms. And kept him within his mother's arms. He's the second of three baby boys, the other two with no health issues at all. In osteogenesis imperfecta, we see poorly mineralized bones with an unusually translucent skull. We see clearer than usual, particularly talking on the proximal hemisphere closest to the transducer. Ho ho. Broken bones. Usually at femur levels. This is bilateral. Also translucent long bones with poor acoustic shadowing or no shadowing at all. And if we see carefully, we can spot some rib fractures. If we use a high resolution linear transducer, we see that misaligned rib. So the head shape is long with short biparietal diameter. This is the BPD chart, and this is the occipitofrontal chart. Long as the anterior-posterior diameters. Among the most common findings on this job are urinary differences, from kidney shape varieties to lethal forms of polycystic kidney disease. There's a wide spectrum of findings. Here we see a pretty evident right kidney hydronephrosis. We saw from head, we go from head to toe, normal face, normal head, normal heart, both lungs. This patient was referred to structural because kidney abnormality. We just saw the three vessels trachea view, and then we saw some anechoic structure here, which is not normal, and is kidney. Bladder is like here, this area. Those are both kidneys. Chance it up, chance transducer, go to nose, go to heart outflow, pulmonary aorta, the apical four chambers, aorta, the kidney, spine, the kidney. So this is a very evident right kidney dilation. Here we see, on the other hand, a borderline pyelic dilation with evidence of peristalsis. You will see the kidney pelvis moving. See that? So measurements about 5 millimeters diameter on the pelvis usually are not a problem. 5 to 10 to be evaluated after a month of extrauterine life. And more than 10 usually will keep with some degree of being a problem. We can also find anatomy variants, some of those relevant for health, like this horseshoe kidney, hard kidney, across the spine from right to left, more on the right side of the kidney fossa. That's a horseshoe kidney with an old machine. And that's zooming in on the kidney length. Is like 5 something centimeters. That's the rest of the abdomen echoes, and that's the kidney. That's the liver, the upper right pole. The lower appears to be under the stomach. So you can see a kidney-like structure which crosses in front of the spine. Enjoy it. You will not see much of those. If you notice, there was some peristalsis on the on the intestinal echoes. So horseshoe kidney. Some other difference with no major relevance. This one is a twin pregnancy. You can notice the respiratory movements. And if we are careful enough, an unusually long peanut-like shape, right kidney, with what appears to be a renal sinus duplication or duplex kidney. Usually not a problem. Abdominal wall defects. This baby shows something hanging into the amniotic cavity from the umbilical insertion site. See those echoes? Free echoes floating on the amniotic cavity. All machine again. Waving high. This is in close relationship with the umbilical vessels. If you move it, you can see the pendulum-like movement.
Start, stop, start, stop.
And that was our sternal platform saying start, stop. I was trying to get a volumetric render reconstruction. On those times, 2010. And here we have volume rendering image of the intestine outside the abdomen of a baby. See this? On the other hand, small omphalocele show like this, as a solid, rounded or somehow rounded mass into the umbilical cord. This thing. Enjoy it. Small omphalocele. 2 centimeters wide, almost 3 centimeters long. And this is an older example of an omphalocele. Also from 2010. All machine. Good machine.
Start. Stop.
That was our, told you, external sonocubic platform. Good old days. But sometimes abdominal wall defects are wide enough to let stomach outside. This is the gastric chamber, outside the abdomen, even the liver. In this picture, the black area is the stomach, and those are small intestine echoes. Also outside the abdomen. In some other patients, we see non-relevant, apparently non-relevant findings, like this baby with an unusually white, bright area on the topography of the gallbladder, which are fetal gallstones. Hopefully you will not see much of this. There you are. The natural history of fetal gallstones. Updated literature review. Take a look at that. Seldom seen. Sometimes we also see babies with high drops. This baby has what we call a total cystic hygroma. from head to hip, even in the limbs. And this another baby, ascites, was due to isoimmunization, a blood type incompatibility problem. That's the abdomen, and that's the fluid. Also showing some liver enlargement. The liver is the largest solid organ on intrauterine life, but not that big. And this is a complex case of a baby with an extrophy complex. Extrophy of the cloaca is a part of the spectrum of birth defects, which go from phallic separation and epispadias to pubic separation, extrophy of the bladder, cloacal extrophy like this baby, and the most severe form, seldom seen, the omphalocele, extrophia, imperforate anus, and spinal defects complex. With the baby showing you now, we saw no bladder filament along the whole examination. It took me like an hour, and a mass-like bulging structure hanging from the perineal area related with the cording section around here. And I'm gonna let the whole video run because, well, you don't see many of these babies. There's the cord with a single umbilical artery, as you can see. And that was the complex mass in the perineal area. See that? And this is a follow-up clip of the same baby. Remember, we don't see the bladder, and we see a bulging complex mass in front of the pelvis. The mass is related with umbilical cord, and in this case, we have a single, we mentioned before, umbilical artery. Follow up. One artery, one vein. Okay, let's move to the heart. Conotruncal abnormalities are like this. We see a four-chamber view, clearly not normal, with a small left ventricle instead of more or less symmetrical ventricles. We know this is the right ventricle because of the presence of this structure. So some abnormalities include malformations of the conus arteriosus and the great arteries, including fallope, truncus arteriosus, interrupted aortic arch, double outlet right or left ventricle, transposition of the great arteries, and aortopulmonary septal defect. Here, what we see here is discordant ventricular sizes with the big right chamber labeled here as VD. The measurement being the left ventricle half the size of the right one when we see the moderator band of, or trabecula septomarginalis trabecula. So this is the label for diagnosing this as a right ventricle. On the aortic outflow, we see a jet in the arch segment, most probably due to certain degree of coarctation, a conal septal defect, and also a second membranous septum defect. With a wide aorta proximal to the jet and coming from the right ventricle. So we have a double outlet right ventricle. Showing here the pulmonary artery, two branches. We can even see the coronary arteries. And in this apical view, we see small left chambers and big right. Here we have a different situation. A single left morphology ventricle. We don't see the moderator band I pointed to you before, and the only ventricular functional chamber is the big left one. This baby was born back on 2002, and our recommendation was to go and be attended at Mexico City National Institute of Perinatology, which is across the street of National Institute of Cardiology. You never know what the baby needs will be. But predictably, Emmanuel, that was the chosen name for him, was going to need very special neonatal care. But as Niels Bohr said, predicting is difficult, especially about the future. And this is the video clip. So we functionally have three chambers. That was a shot for the fetus.net website of my teacher, Dr. Philip Genti. May him God rest in peace. With the double outlet, and here in color, remember we were more than 20 years ago with an already old machine. So as I told you, making predictions difficult, especially about the future. The baby is now older than 20 years. As far as I know, needed no correction or even oxygen supplementation. Not at birth, not now. Okay, with this other baby, we see a small heart with an image showing like three chambers heart and small pleural effusion. The transverse heart diameter is the one of for 19 weeks baby and not at 13 weeks, which was actually the gestational age of this baby. Small heart. We see a small left ventricle and a very hypoplastic aorta. Some other babies showing something like this. You can see a heart and echoes free bubble along with both lungs. Apparently the heart is displaced right as well as the aorta. And when we put some color, we confirm as a right-sided aorta. And this is the bubble located between the lungs. So this is the right and left lung and the mass or cyst, which happens to be the gastric chamber. So this baby has a posterolaterally located defect on the diaphragm, which gives the diagnostic of a Bogdan leg type hernia. See the defect? With a dextro-positioned heart and aorta and no pulmonary hypoplasia shown at the time of this examination. Labels are spina, xiphoid, stomach, heart, right and left lung. Here we have a second baby with such problem, stomach, heart, displaced right. This is the xiphoid, this is the spine, and those are the lungs. And obviously dextro-positioned aorta and heart. And here we see the liver marked H for liver, and both lungs marked P for pulmones, Spanish, as well as stomach with that E for estomago. Spanish lessons are for free. So back to complex syndromes, here we see a baby who is 14 to 15 weeks affected by a total lymphangioma or hygroma. Echogenic large for dates kidneys, which usually means some form of polycystic kidney disease. Ascites as well as pleural effusion, so technically speaking, is a hydrops situation. Pleural effusion, ascites, with edematous, fixed, flexed limbs. Here we can see what means total cystic hygroma. So hydrops and flexed limbs usually mean some severe form of congenital arthrogryposis, usually lethal. Kidneys which are more echogenic than usual and large or borderline large for ages with normal amniotic fluid amount are usually found in people who is going to develop adult kidney cystic disease. This is genetic and usually related to a lack of formation of tubes inside the kidneys. They can also develop pancreas or liver cysts. And if we see maternal kidneys to show cysts like this, and subtly more echogenic or enlarged kidneys on the baby, we can mention the possibility for the baby to come and develop in the future same spectra than the mother in adult life. And the more lethal presentation of polycystic kidney disease is a baby who does not urinate. So we see no amniotic fluid or very little amniotic fluid. Here we see a placenta, no fluid at all, and some fetal parts. So this is a 16 to 17 weeks baby with a kidney which goes all the way from the diaphragm. See this triangle shaped thing is the lung. And this spot is hip bone. So the kidney takes all the space in between the lung and the hip. All machine shot, by the way. That's the right kidney, as we see the liver above the kidney. This is the liver. Try to image babies here. And now the left kidney, same baby, where we can locate smaller triangle shape thing on the left side, left lung, and a clearer hip bone, the kidney. So some of those babies grow older as this one who is 26 weeks with a narrow thorax, no amniotic fluid surrounding the baby, wide abdomen, narrow thorax. All machine. And kidney large for age. This is the kidney contour. It's a polycystic kidney disease, lethal form. While some of those kidneys are really more echogenic and easier to recognize, like this one. Those are both kidneys. And now some of you will remember this baby from our pelvis abnormal ultrasound masterclass as a female baby with a cystic mass, which is no stomach, no bladder, and no kidney in a location close to the bladder. So this was the antenatal presentation of malignancy to be underestimated and confirmed several months after birth. You will remember this as a pelvic mass. This is an ovarian cyst. Diagnosed as soon as in utero and underestimated to be left to the natural evolution of this germinoma. Not nice. Well, when we see not 3, not 4, but more echo-free images inside the abdomen being no kidneys, we can call the chance for the jejunal atresia. Usually the biggest bubble is the gastric chamber. And let's take a look at the video clip. So you will not forget these images which are labeled like number 1, stomach, gastric chamber, number 2 and 2, abnormal bubbles, small intestine, dilated, cystic masses inside, and the number 3 being the urinary bladder. Yes, the biggest bubble was not the stomach, but below the stomach, probably duodenum. In ultrasound examinations, we also can see uterine ruptures, like this one with high-resolution transducer. The pubic bone is on this side, and with the convex further. This is a bulging thing in front of the uterine scar. You see the video clip. We can see the baby moving inside, pushing the membranes. And some echoes inside as amniotic fluid. We can measure the volume. We change the convex, the regular transducer we use for obstetric examination. We confirm the bubble in between the bladder and the amniotic fluid, and some flow on it coming from the uterus. See that? So that's a uterine rupture covered by amnios, or perhaps by the parietal peritoneum. Or placentas like this one fully covering the cervical inner orifice. Those echoes are placentary echoes covering the area of the cervix. That's placenta previa, total placenta previa. We had no signs of accreta, but remember this was 11 years ago, 11 and a half years ago. We didn't use the same technology as today. We see the basal plate very clearly with the blood vessels. So, at a glance, normal symmetrical head, no dilated, absent of or abnormal structures seen. Abnormal or absent skull. Seriously dilated ventricles. Sided abnormality because something is inside the skull. Normal face, abnormal face. Normal orbital relationships and abnormal orbital relationships. Heart normal 4 chambers good. Functionally single ventricles. At the left side, left morphology, and at the right side, right morphology, single ventricle. Well, this last with small recognizable left chambers. Chest. Heart pointing left plus 2 lungs. Small heart, some pleural effusion. Gastric chamber on the chest and heart displays right. And believe it or not, this is a chest image too. I will show you the context a bit later. 2010. On the abdomen, the two more evident fluid-filled structures. This is gastric chamber, urinary bladder, gastric chamber. Below the diaphragm, and not this bunch of black holes which shows intestinal atresia. Kidneys like this are normal, and not like this one, which is bigger. And within the the grayscale position of this is more like a lung than a normal kidney. This is nearer the white side of the spectrum, whiter than normal, to make it simple. The wall of the abdomen, the abdominal wall, looking like this. And of course, not like this, the omphalocele, or the gastroschisis, or laparoschisis, you can call it. And of course, not like this cloacal extrophy with no bladder seen inside. Spine like this, and not like this, covered by skin meningocele. Long bones in normal measurement range, without the moth bites this shows, or these ugly fractures. That was easy anyway. I hope you never encounter a problem like this one I would like to share. This is the last video clip of the presentation. So here we see twins, 2 heads, profile shot. And this peanut shaped structure which shows us conjoined twins, thoracopagus, with a single heart or two attached hearts, whatever this is. I'm not skilled enough to, and I was not 2010 to decipher this. Two stomachs, two livers, four kidneys, but functioning one heart for both. In the meantime, we see this complete, complicated examination from 2010. I want to thank everyone and each of you for your attention and your will to improve skills. This is a really modest effort to help. This is designed for providing you just basis for finding more things. Not because we want people to be sick or to live with a difficult life, but because we all need to be more helpful for others. Remember, it's not the machine you use, but the care you give. We deal with persons, not cases. And our empathy can change everything. Ultrasound, yes, can be the very best way to terrify a mother. But please, not in our shift, not from our big mouths. Thanks a lot and God bless. Can give you homework. One of the truths of genetics is we all are normal. The other truth is there's a wide spectrum of normality, and we are mostly genetics.